Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz on the radio live preparation for the NEET PG. Archana, Shweta, and many more who are all online. Shweta, am I audible?
Yes, sir.
Great. Archana, are you there?
Yes, sir.
Wonderful, wonderful, wonderful. And many more students who are all online, you can all join into this daily live online with Dr. Murali Bharadwaz for 1 hour of revision, which will add energy, petrol into your preparation. I'm joining from Hyderabad. Hyderabad today has a beautiful skyline with the sunset, and I'm really enjoying becoming a NEET PG aspirant once more every day with all of you. And if we all prepare together every day for 1 hour, you answer questions live without any PowerPoints, without any videos, without any other drama. If your ears are working to the fullest, the way you learn, recall, and re-emerge with all that energy will be far, far, far superior than going to any cramped, crowded classroom. So, doctor, let's make the great beginning. Uh, Let us start with the favorite topic of the examiner, which is sleep. Let's look at sleep. Now, sleep has so many stages. 1 minute. Okay, sleep has so many stages. You need to be very sure about all these stages of sleep, and also what is the EEG activity. Now, I'm going to quickly give you 10 points about the sleep, which are the favorite questions of the examiner. First, your eyes are open, you are awake. What type of EEG waves do you get? Beta, highest frequency, lowest amplitude. Second, your eyes are closed, not open, closed, but still you are awake. Then what do you get? Alpha waves. If it is a non-REM sleep, basically there is after awake you have non-REM, after non-REM you have REM. So typically non-REM has stage 1, stage 2, stage 3. Non-NREM stage 1, 5%. NREM stage 2, 45%. NREM stage 3, 25%. So totally 5 plus 45 plus 25 is 75% of our sleep is non-REM sleep. Now, there are 3 waves you should remember in non-REM sleep. Non-REM stage 1 theta, non-REM stage 2 sleep spindles and K complexes, non-REM stage 3 delta. Non-REM stage 3 is the deepest sleep stage, and these delta waves which you see in this deepest sleep stage, which is the stage 3 of non-REM, typically you have the delta waves. Delta waves are lowest frequency, highest amplitude. And what are the waves? Just before we said Shweta, Archana, when our eyes are opening, when you are awake, what is that wave called?
Beta waves.
Very good. So the beta waves have highest frequency, lowest amplitude, whereas the delta waves, which are the part of the deepest sleep stage, they have lowest frequency, highest amplitude. That is what you need to remember. Then, there are 3 more points you should remember. The stage 1 of NREM you call light sleep. Stage 2 of NREM is when bruxism, that is grinding of the teeth, happen in the stage 2 of NREM. So many times this question was asked in the NEET PG exam. I will feel sad if someone says, I'm taking NEET PG, but I'm not sure about EEG waves. Means, oh my God, you're not even there in the competition. All right. So you beg, borrow, steal, bite, but you need to be 100% precise on this, right? She should be 100% precise. So the stage 2 of NREM, bruxism. Stage 2 of NREM, sleep spindles, K complexes. All right, you won't forget. So once more, I'm revising for you. Awake, eyes open, beta. Awake, eyes closed, alpha. NREM stage 1, theta. NREM stage 2, sleep spindles and K complexes. And NREM stage 3, delta waves. Remember? Now, REM sleep. REM sleep constitutes 25%, NREM constitutes 75%. In the NREM also, stage 2 is 45%. So majority of our sleep will be tooth grinding, sleep spindles, K complexes, and we are in the stage 2 is what you need to remember. Now coming to the REM sleep, what do you get? Once more the beta waves will reappear. When your eyes are open and you are awake, you have beta waves, no? The same things will reappear when you have the REM sleep. Now, what are the important things about REM sleep? In the REM sleep, there's a loss of motor tone. There's an increase in the oxygen usage by the brain. There is a variable pulse. There is a variable blood pressure. There's an increased acetylcholine. All these things you see in REM sleep. REM is the time when you are dreaming. You got that wonderful prince riding on the horse coming to pick you up and going to that fantasy world. That is REM sleep. REM sleep also will be nightmares. REM sleep is the time where penile tumescence, clitoral tumescence typically occur. And REM sleep is the time where all your memory processing, typically memory processing will occur. That's the reason when you prepare for the entrance, good sleep is needed. That's the only way all your, whatever that you are reading will become processed well, right? Then REM sleep is the time where the extraocular movements occur. There's an area in the pons called peripontine reticular formation. So this is the place where all these extraocular movements occur. That is during REM sleep. And REM sleep occurs every 90 minutes. And this duration will keep increasing through the night. So this is the story of REM sleep. Now comes the question, doctor. Whenever you are aging, बुढ़ापे में सोने में दिक्कत होता है. To sleep, it becomes difficult. So is it the REM or NREM affected? Sir, when we become old, REM decreases. Then in the NREM, the third stage will decrease. The sleep latency will increase. Very early awakenings occur. Now, what are the changes that happen during depression? Depression also. REM sleep will increase in depression. Whereas in elderly, REM sleep decreases. Depression, REM sleep increases. Similarly, the REM latency will decrease in depression. Whereas elderly, the REM sleep latency increases. Then in depression, the stage 3 of NREM decreases. This is one thing which is common between elderly and depression. Even in elderly, N3 phase of NREM decreases. Even in depression, N3 phase of NREM decreases. That's what you need to remember. And with depression, repeated nighttime awakening occur, early morning awakening. That's called terminal insomnia, is a feature of depression. That's what you need to remember. Then finally, there is a condition called narcolepsy. So typically the people who have narcolepsy will be quickly falling into sleep while बैठते or sleep में चले जाते. That is narcolepsy. They lose the muscle tone, everything. What is the problem in these people? In these people, REM latency decreases in narcolepsy. So these are the points you should not forget, doctor. Everything about the sleep. One more point before I conclude, I like to ask you. I want to tell you, night terrors, bed wetting, sleepwalking, all these things occur in the stage 3 of NREM is what you need to remember. Now, are you ready for the game? Can I ask you questions?
Yes, sir.
Yes. Now let me see how much you recall. Let us start. What happens to the stage 3 NREM in depression?
Decreases.
It decreases, sir.
Very good. In the elderly, what happens to the stage 3 of NREM?
Decreases.
Very good. What happens to REM in depression?
It increases.
It
REM increases.
very good. And what happens in elderly people to the REM?
It decreases.
Very good. And early morning awakening is a feature of?
Depression.
And narcolepsy may what get affected, REM or NREM?
REM latency.
Latency is decreased.
Very good. Now, when I am awake with the eyes open, what is the type of the EEG waves which are expected?
Beta waves.
Beta waves.
Very good. And stage N2? Stage
Sleep
2
spindles.
of NREM.
Sleep
K
spindles and K complex.
Very good. And stage 3?
Delta waves, sir.
Very good. And REM sleep, what are the waves?
Sawtooth waves, sir.
REM
No,
sleep,
beta
what are
waves
the waves?
reappear.
Waves.
So beta waves.
Very good, very good. And tooth grinding, bruxism, when will it happen?
N2. NREM
Second
stage 2.
stage of NREM.
Very good. When do the alpha waves occur?
Eyes closed but
Eyes are
awake.
closed but
Very good, very good. And penile and clitoral tumescence.
in REM sleep.
REM sleep, very good. In REM sleep, we get penile and clitoral tumescence. And nightmares, when will they occur?
In REM.
Nightmares in REM sleep, sir.
In REM sleep, REM sleep. And night terrors,
NREM 3.
which stage?
Third stage.
Third
Third
stage.
Very good. So, all the fear about the sleep is over. We are now the champions. All right. Now, let's pick up the next interesting area, a dirty area, which we need to properly get it cleaned before we go to the exam. Right now, what is that area I'm talking? The nuclei of hypothalamus. Examiner will play with our life in the tomorrow's NEET PG exam if we don't do this, we don't prepare for this correctly. Now let us look into it. Basically, we have lateral nucleus, ventromedial nucleus, anterior nucleus, posterior nucleus, suprachiasmatic nucleus, supraoptic nucleus. We need to know everything about it. Lateral nucleus. Lateral nucleus, typically hunger, and any destruction of lateral nucleus will lead to anorexia. In infants, failure to thrive. The lateral nucleus. So lateral nucleus normally makes us hungry. Any destruction lead to anorexia and fail to thrive. Lateral nucleus is stimulated by ghrelin, whereas inhibited by leptin. Barabar? That's the reason ghrelin will make us hungry, leptin will make us anorexic. That's what you need to remember. Ventromedial nucleus. Ventromedial nucleus is all about the satiety. Yes. Already 3 pizzas over, mama. I don't want the 4th pizza. Satiety. Ventromedial nucleus. Any destruction of the ventromedial nucleus, typically craniopharyngioma, it happens. Ventromedial nucleus, that makes us hyperphagic. जितना भी खाओ और खाने का मन लगता है. That is ventromedial nucleus. Ventromedial nucleus is stimulated by leptin. Whereas lateral nucleus is inhibited by leptin. That's what you need to remember. Anterior nucleus. Anterior nucleus is all about cooling and parasympathetic. Posterior nucleus is all about heating and sympathetic. So how will you remember this? जरा कूल होना बोले तो क्या करते हैं आप? AC लगाओ. A होता है anterior hypothalamic nucleus, C होता है cooling, AC होता है anterior cooling. Posterior का बात बोले तो obviously opposite होता है heating. Then suprachiasmatic nucleus is circadian rhythm, all of you know. Supraoptic and paraventricular nuclei are for the ADH. Supraoptic is for ADH. Paraventricular is for oxytocin, is what you need to remember. Then preoptic nucleus. Preoptic nucleus होता है thermoregulation. Sexual behavior, release of gonadotropin releasing hormone. That is preoptic nucleus, right? So thermoregulation, sexual behavior, and GnRH release. How will you remember this? Oh, this guy is very hot, we say. Hot होता है thermoregulation, but actually it is something to do with sexual behavior, right? So thermoregulation, sexual behavior is all about the preoptic nucleus, is what you need to remember. Are you ready for a quick answering?
Yes, sir.
Sir.
Very good. Good to see Dr. Keshav. Keshav, which medical college you are from? Keshav, are you there?
Sir, good evening, sir.
Good evening.
Sir, this
From
is
which
Andhra
college?
Medical College. Andhra Medical College, sir.
Excellent. Andhra Medical College means you are like talwar ke tar ke jaise ho. You are like the edge of a sword. You know, most brilliant guys get into Usmania, Andhra Medical College, Vizag, etc. Good to see you. So Keshav, Shweta, Archana, and many more who are all online, I want to tell you that there are many wonderful ways of preparation. Suppose if you are writing on a notes, you will forget. If you are watching a PowerPoint slide, you will forget. If you are watching a video, there is no guarantee. After some point of time, you will become passive. The best way to remember is when you are the part of a conversation. Audio is the powerful way. Nothing before you, your attention is all glued only to listening. One sensory thing, that is audio, will make you to remember for the exam tomorrow very well. All right? So with that
Yes, sir.
preamble, let me quickly run the questions of what I just before discussed. All right? Now, tell me, hunger to become hungry is because of which hypothalamic nucleus?
Lateral nucleus.
Very good. What is the action of ghrelin and leptin on lateral nucleus?
Ghrelin stimulates lateral
The
nucleus.
stimulatory, leptin inhibitory.
Very good. And what is the nucleus associated with satiety? Satiety.
Ventrimeterial nucleus.
Ventrimeterial.
Very good. What is the effect of it? Leptin on it?
Stimulatory.
Stimulates. Leptin stimulates ventrimeterial nucleus.
Stimulates. Very good. Between anterior and posterior nucleus, which is heating, which is cooling?
Anterior
Anterior is
nucleus is cooling.
Very good. Anterior is cooling, posterior is heating. And ADH is by which nucleus? Oxytocin is by which nucleus?
Oxytocin by
Supraoptic is
paraventricular.
Very good. ADH is by supraoptic,
supraoptic.
paraventricular is oxytocin. Okay, so that is very good, doctor. Now comes a very important question that we are going to revise, and that is about the thalamic nuclei. Thalamic nuclei. Now I will quickly give you the summary. While I give the summary, you can put your mic in a mute mode so that background noises don't come. So after I give summary, I'm going to quiz you. All right. Now, ventro-posterior-lateral nucleus. What is that called? VPL. VPL nucleus is important for what? Vibration, pain, pressure, proprioception, light touch, and temperature. Vibration, pain, pressure, proprioception, that is conscious proprioception, light touch, and temperature. VPL nucleus, typically input is spinothalamic pathway, which is bringing temperature, and dorsal columns and medial lemniscus, which is bringing vibration, position, and light touch. And VPL nucleus ultimately leaves the efferents. Where will they reach? They reach parietal lobe, the primary somatosensory cortex. That is about the VPL nucleus. Then ventro-posterior medial nucleus. It's also called VPM nucleus. So what is the input? Throughout the body, all our temperature, everything is brought by whom? The spinothalamic tract. Touch and position and all those sensations are brought by whom? Throughout our body, dorsal columns. But from our face, from the face, who brings the touch, temperature, all these things? Trigeminal. So the trigeminal bringing the sensations from the face go to the ventro-posterior medial nucleus, while the whole body temperature, touch, vibration will go to ventro-posterior lateral nucleus. That's the difference. Taste, once more, the taste pathway, gustatory pathway, that also will go to ventro-posterior medial nucleus. And where will the efferents from here will go to? They will also go to the parietal lobe, which is in the primary somatosensory cortex. Then the third important nucleus you need to know about thalamus is lateral geniculate nucleus, medial geniculate nucleus. So what will you remember? Lateral carries light, medial carries hearing, that is music. Medial is with auditory pathway, medial geniculate nucleus. Lateral geniculate nucleus is associated with vision. So easy to remember is lateral is light, medial is music, is what you need to remember. So from where lateral geniculate nucleus associated with the vision is receiving the fibers is my question to all of you. So it is the optic nerve, optic chiasma, optic tract that ultimately goes to lateral geniculate nucleus in thalamus. Where will the input for bringing the auditory sensations to the medial geniculate nucleus come from? Superior olivary nucleus. inferior colliculus of the tectum, you are getting information. So superior olivary nucleus, inferior colliculus, they both are input to medial geniculate nucleus associated with the auditory pathway. In Telugu, I think our Keshav can appreciate this better. In Telugu, we used to remember like superior colliculus sustadi, inferior colliculus intadi. Intadi means listen in Telugu. So inferior colliculus is with auditory and superior colliculus is associated with vision, right? That's what you need to remember. Lateral geniculate nucleus is associated with vision. Medial geniculate nucleus is associated with the auditory. That's what you should remember. Finally, there is ventro-anterior, ventrolateral nuclei. What are they associated? Thalamic nuclei. They receive all the input from the basal ganglia and cerebellum. So basically, all our motor fine-tuning of our motor activity is controlled by your cerebellum and basal ganglia. So the basal ganglia and cerebellum, they send the information to ventro-anterolateral nuclei is what you need to basically remember. Ventro-anterior nucleus and ventrolateral nucleus. This is the story. Are you all ready for the quiz? Archana,
Yes, sir.
Shweta, everybody?
Yes, sir.
Yes, sir. Yes, sir.
Very good. Now my question shooting to you is, inferior colliculus will give information to which nucleus of thalamus?
Medial geniculate.
Very good. Cerebellum communicates with which thalamic nucleus?
Ventrimeterial Nucleus.
Very good. And the gustatory pathway will report to which nucleus?
Ventroposteromedial.
Ventroposteromedial. Very good. And the pain and vibration, pressure, all that will report to?
DPL, ventroposterior lateral.
Very good. Medial lemniscus communicate with? See, your vibration, proprioception are carried in spinal cord by dorsal column. The moment the dorsal column reaches the lower part of medulla, it will decussate to opposite side and that continues as medial lemniscus. You will remember it? Basically, lemniscus का मतलब क्या होता है? What is meant by lemniscus? Lemniscus is that neural pathway that carries the second order neurons. So if you take the touch and vibration sensation, primary, the first order neurons are all carried by the dorsal columns. They reach the lower part of the medulla, bringing all the touch from your feet, from hands, everywhere. Once it reaches the lower part of the medulla, it decussates to opposite side and it ascends up in the form of medial lemniscus. So just before you told na, vibration, proprioception, everything report to VPL. So how do they report? They start as dorsal column, they reach the lower part of medulla, they decussate opposite side, travel as medial lemniscus, and ultimately land in thalamus in the VPL nucleus. Barabar?
Yes, sir.
Now, superior olivary nucleus communicates with which thalamic nucleus?
Inferior colliculus of tectum and then medial geniculate nucleus.
Right. Superior olivary nucleus, inferior colliculus of tectum will ultimately land with medial geniculate nucleus. Very good. Basal ganglia control the motor activity by communicating with?
Ventroanterior and ventrolateral.
Ventroanterior and ventrolateral. Now you have confidence on thalamic nuclei and hypothalamic nuclei, right?
Yes, sir.
So we finished with three important topics: sleep, thalamic, hypothalamic. One time if you read, you should not read one more time. That is the strength with which you should read it. That can only happen if you're a part of a conversation like this, all right, where you have the attention. All right. Next thing that we are going to master is, for a small break, let's quickly go to which topic we want. All right. So let me think. Where will I take you? All right. Let me take you to. Okay. I'm trying to identify those topics which require some amount of sort of a memory kind of a thing, right? So where only in a combined study you all can remember. All right. Let me quickly take you to favorite 5 topics of the examiner. Fanconi syndrome, Bartter syndrome, Gentleman syndrome, Liddle syndrome, SIADH. This is, and Con syndromes, not SIADH, Con syndrome. These are the 5 syndromes I want to make you strong before we call off this session, right? Now, first let us talk about the Fanconi syndrome. Now, doctor, what is the defect? What is the effect? What is the cause? And 2-3 points about it we are going to master. All right? Now, Fanconi syndrome, where is the problem? The problem is in the proximal convoluted tubule of the kidney. Once more, into your mind, suddenly start thinking about the kidney and the structure, right? Fanconi syndrome, the problem of a reabsorption defect in proximal convoluted tubule. अच्छा भाई, proximal convoluted tubule में किसका absorption होता है? What is normally reabsorbed in the proximal convoluted tubule? Amino acids, glucose, bicarbonate, phosphate. Amino acids, glucose, bicarbonate, phosphate, they're all absorbed, reabsorbed in PCT. Any problem of that, what will happen? Bicarbonate cannot reabsorb, you get bicarbonate in urea. Phosphate cannot reabsorb, you get phosphaturia. Amino acids cannot reabsorb, you get amino aciduria. Glucose cannot reabsorb, you get glucosuria. Yes. Now, what is the effect of this? Because there is a phosphaturia, patient develops hypophosphatemia. Then, because the problem, the bicarbonate is lost in the urine. Because of that, patient develops metabolic acidosis. Because bicarbonate is a normal buffer of acid in the blood. If it is lost in the urine, the patient develops metabolic acidosis. In addition to that, patient also develops hypokalemia also. Hypokalemia also is what you need to basically remember. So metabolic acidosis, hypophosphatemia, hypokalemia are the effects of this reabsorption defect in proximal convoluted tubule in the case of the Fanconi syndrome is what you need to remember. Now, if there is no phosphate, if we have hypophosphatemia, what is the effect of that? If I'm a small kid, I develop growth retardation, I develop rickets, I develop osteopenia, and also proximal convoluted tubule. If it is defective, majority of the water is reabsorbed in the proximal convoluted tubule. But if it is defective, then the person will go into volume depletion and hypovolemia, significant hypovolemia. Now, what are the causes of Fanconi? 5 things you should remember, doctor. What lead to proximal convoluted tubular dysfunction leading to Fanconi syndrome? विल्सन्स डिजीज, आपको याद है ना, कल हमने डिस्कस किया विल्सन्स डिजीज, टायरोसिनेमिया, ग्लाइकोजन स्टोरेज डिजीज, any ischemic injury, typically the patients who are road traffic accident, they lost blood, they will develop proximal convoluted tubule hypoxic injury. Similarly, multiple myeloma affects proximal connective tissue. Certain nephrotoxin like ifosfamide and cisplatin lead to Fanconi. Lead poisoning lead to Fanconi. So once more, Wilson's, tyrosinemia, glycogen storage disease, ischemia, multiple myeloma, nephrotoxins like ifosfamide and cisplatin, and lead poisoning is Fanconi. Kush Hua Mogambo. Now you know about Fanconi. Tomorrow examiner दिए तो थप्पड़ मार के आंसर करना है कल के एग्जाम में. Exam is all about confidence, doctor. Lot of times क्या होता है? We tend to postpone. Like marriage is postponed, pregnancy is postponed. Similarly, we postpone a lot of things in life. Unfortunately, that is what is the problem of postponement. So every day you are studying means, along with Dr. Murali, you'll remember. Now, doctor, the next thing I'm going to tell you is, I think we lost Dr. Keshav. Yeah, Keshav also joined. Keshav, you can mute the mic. That's better. Yeah. Now, let us talk about the Bartter syndrome. 5 points about Bartter syndrome, doctor. That's all. I'm not expecting you more than that. Bartter may problem is thick ascending limb of loop of Henle is the one which is affected. What is the normal function of thick ascending limb of loop of Henle? Here you have sodium, potassium, 2-chloride co-transporter. Can you tell me one drug which typically acts on sodium, potassium, 2-chloride channel? Furosemide. All your loop diuretics, they will cause diuresis by inhibiting the sodium, potassium, 2-chloride co-transporter. That is the reason Bartter syndrome is like taking the loop diuretics is what you need to remember. Now, why do you get Bartter syndrome? Autosomal recessive disorder. आपके हाथ में नहीं है, अब्बा और दादाजी के हाथ में है जहां पर Bartter क्यों आता है? क्योंकि ग्रैंडपा भी Bartter था. Now, what will Bartter do? In Bartter, you get metabolic alkalosis, not acidosis, alkalosis. Whereas Fanconi syndrome, you get metabolic acidosis. Bartter mein, you get metabolic alkalosis. Just like if you are taking a diuretic, what will happen? If you take a diuretic, you become volume contracted. It's like you become dehydrated, plasma volume decreases. Whenever plasma volume decreases, the blood flow to the kidney also decreases. When the blood flow to the kidney is decreased, what will happen? There is renin-angiotensin system that gets stimulated. If the renin-angiotensin system is stimulated, what will happen? Renin-angiotensin system, if it is stimulated, then aldosterone is produced. If the aldosterone is produced, what will happen? Aldosterone will cause sodium retention and potassium loss and H plus ions loss into the urine. And the loss of H plus ions into the urine will cause metabolic acidosis or alkalosis? Metabolic alkalosis. Understand? So how will you remember metabolic alkalosis and hypokalemia and Bartter syndrome? Simple way. Bartter is inhibiting the sodium potassium 2-chloride co-transporter in the loop of Henle. If the sodium potassium 2-chloride co-transporter is inhibited, it is as good as taking a loop diuretic like furosemide. If you take a furosemide, you are getting dehydrated. Dehydration leads to decreased plasma volume. Decreased plasma volume decreases the renal plasma flow. Decreased renal plasma flow stimulates the renin-angiotensin system, and that leads to high aldosterone. Aldosterone will cause retention of sodium and loss of potassium and H plus into urine. Loss of potassium into urine will lead to hypokalemia. Loss of H plus into urine will lead to metabolic alkalosis. That is the reason you need to remember Bartter syndrome lead to metabolic alkalosis. Bartter syndrome lead to hypokalemia. Bartter syndrome is like taking the loop diuretic. Bartter syndrome may sodium potassium 2 chloride channel in the thick ascending limb of loop of Henle is defective. And whenever you take loop diuretics, normally what happens? Loop diuretics lose calcium into the urine. That is the reason, just like that in Bartter syndrome also, you get hypercalciuria. So metabolic alkalosis, hypokalemia, hypercalciuria defines the Bartter syndrome is what you need to basically remember. Maza aa gaya na? Now, the next thing is Geniculate. I told you, 5 syndromes आपके जिंदगी तमाम याद रखना है. एंट्रेंस में टॉप रैंक आना बोले तो ये 5 को आप मास्टर करना है. अगर मुरली भरद्वाज का स्टूडेंट्स है तो Franconi, Bartter, Geniculate, Lateral cons. ये 5 syndromes में क्वेश्चन आए तो मिस्टेक करे तो Murali Bharadwaz soul will be heaving in the graveyard, right? So that's the reason you have to be champions. Now, doctor, the next thing you need to remember would be the Geniculate. So what is Geniculate? Geniculate is a problem in the distal convoluted tubule is what you need to remember. Am I audible? Shweta, Archana, good to see Vanilla. Am I audible?
Yes, sir.
Very good, very
Yes,
good.
sir.
Now, Geniculate. Geniculate is a problem in distal convoluted tubule. Geniculate is a problem in defect of reabsorption of sodium chloride. Sodium chloride. Can you tell me which diuretic inhibits the distal convoluted tubule? Mechanism of action of which type of diuretics is inhibition of distal convoluted tubule? Anybody? Vanilla?
Thiazide diuretics.
Wonderful. Thiazide diuretics. Excellent, excellent. So, Geniculate also is like taking a thiazide diuretic lifelong, but it is less severe than Bartter. Less severe than Bartter. Even Geniculate is also autosomal recessive. Even Geniculate also will make the patient land in metabolic alkalosis, hypokalemia, hypomagnesemia. But there is one important difference you should remember. Normally also, loop diuretics lose the calcium into urine, but thiazide diuretics retain the calcium into the urine, into the blood. Loop diuretics lose the calcium into urine, whereas thiazide diuretics retain the calcium into the body. That is the reason hypercalciuria is the feature of Bartter syndrome. Hypocalciuria is the feature of the Geniculate syndrome. You are not going to forget every time examiner, whether you go to USMLE, PLAB or any exam, same question is asked. All right, doctor. Now, the last thing is Liddle syndrome. Liddle syndrome is autosomal dominant. Bartter, Geniculate, autosomal recessive. Please remember, right? Now, what is the problem in in a Liddle syndrome? The problem in the Liddle syndrome is typically the collecting tubules. In the collecting tubules, normally what happens? Aldosterone will come. Aldosterone, if it acts on the collecting tubule, it will open one channel called sodium channel. Sodium channel. And that sodium channel, if it opens, that leads to retention of sodium and loss of potassium and loss of H plus into urine. That is the normal function of aldosterone. Or एक बार बोलो Shweta, what will happen if the aldosterone, where does it act and how does it act? What is the effect of it? Shweta?
It acts on collecting tubules, sir, and it opens the sodium channels,
Very good.
and it leads to sodium retention and loss of potassium and H plus in urine.
खुश हुआ मोगैम्बो. Very good, very good. देखो PowerPoints, videos, ये पूरा हंगामा है तो attention नहीं रहता. Only if you have to give your ears, lend your ears to Dr. Bharadwaz. और एक बार पढ़ने का जरूरत नहीं होना. You should not think about revision, last moment, panic to this and that. No. Very less baggage होना है last moment before exam. Light रहना है आप. एक प्लेट इडली में एक इडली खा के उतना लाइट रहना है, not chicken biryani, right? उतना heavy नहीं होना. I have revised this. Oh my God, I have revised this. Oh my God, I have revised this. You should not be like that. Now only you have to nail down everything so that you go cheerfully to the exam hall. Anything, let it come. I can beat it. That should be the confidence. All right. Now, in the Liddle syndrome, the problem that typically happens is in the Liddle syndrome, this regular sodium channel, which is stimulated by the aldosterone, the sodium channel. That sodium channel typically there's a mutation that will come in the gene that creates that sodium channel that is called gain of the function mutation. Because of that, what happens is, even though there is no aldosterone nahi hone ke baad bhi, that sodium channel becomes stimulated, and that leads to excessive sodium reabsorption and continuous loss of K plus and H plus into urine. So the problem is gain of the function mutation of the sodium channels which are there in the collecting tubules. That is the problem in the Liddle syndrome, which is autosomal dominant, is what you need to remember. So what will happen because of this? What is the effect of it? Sodium is retained, patient develops hypertension. Potassium is lost, hence hypokalemia. H plus is lost, hence metabolic alkalosis. These are all the things that you see in Liddle syndrome. But what is the difference between hyperaldosteronism versus Liddle? Hyperaldosteronism versus Liddle. What is hyperaldosteronism? Typically, aldosterone is produced by the adrenal. If there is any adrenal adenoma, that leads to hyperaldosteronism. What is the difference between that hyperaldosteronism of adrenal adenoma versus Liddle syndrome? Typically, in Liddle syndrome, without aldosterone only, this excess sodium retention is happening. That is the reason the retained sodium will cause the aldosterone suppression. Whereas in the Con syndrome, it is the high aldosterone, which is the primary event, which is causing the sodium retention. So that is the reason high sodium, high aldosterone is equal to Con syndrome. High sodium, low aldosterone, which is suppressed, is what you see in Liddle syndrome. That is all the story of Liddle syndrome, is what you need to remember. Now, doctor, are you all ready for the game? Can I ask you questions? How much you have remembered, retained, and read? Yes. Are you ready for a fight?
Yes, sir.
Yes, sir.
Very good. Now, tell me quickly, what are those hereditary defects that lead to Fanconi? Come on, doctor.
Wilson's glycogen storage disease,
Tyrosinemia,
Very good.
tyrosinemia,
Wilson
Wilson
tyrosinemia, glycogen storage disease, you should remember. Now tell me, what is the hematological disorder that can lead to Fanconi?
multiple myeloma,
multiple
Super. And what are the two drugs, chemotherapeutic drugs you need to remember for Fanconi?
cisplatin,
cisplatin,
Very good. Cisplatin and ifosfamide. And which poisoning can lead to Fanconi?
lead poisoning,
Very good.
lead
Now
poisoning,
tell me, what is the electrolyte disturbance and what is the acid-base disturbance in Fanconi?
hypokalemia, hypophosphatemia, metabolic acidosis.
Very good. Now, between Barter, Gitelman, Little, which is like taking Lou Berwick?
Barter's.
Very good. And which is like thyroid epic?
Gitelman.
Very good. And where do you give amiloride as a treatment? In which condition? Amiloride. Amiloride is given as a treatment in? Amiloride inhibits the sodium channel in the collecting tubules. Now tell me, where do you use amiloride?
Liddle syndrome.
Liddle syndrome, amiloride is the treatment. Very good. Now tell me, what is the acid-base disturbance and dyslipidemias in the Barcher?
Metabolic alkalosis,
and hypokalemia.
hypokalemia, hypocalcemia.
How will be the urinary calcium in Barcher?
Hypercalciuria.
Very good. And how will be the calcium excretion into urine in Gitelman?
Hypocalciuria.
Hypocalciuria, hypercalcemia.
Hypocalciuria. Then how is potassium in plasma in Gitelman?
Hypokalemia.
Hypokalemia.
Yeah. Magnesium in Gitelman.
Hypomagnesemia.
How is the magnesium in Gitelman?
Decrease.
Hypomagnesemia.
Very good. Acid-base disturbance?
Metabolic alkalosis.
Beautiful, beautiful. So metabolic alkalosis, hypomagnesemia, hypokalemia, hypocalciuria. So the two differences between Barter and Gitelman, every time favorite question. Barter will have hypercalciuria, Gitelman will have hypocalciuria. And Barter will have normal magnesium, but Gitelman will have hypomagnesemia. All right. Now, where is the problem in Liddle syndrome?
Collecting tubule.
What happens in collecting tubule?
Sodium channel defect.
Gain of function of sodium channel.
Very good. And because of that, what are the electrolyte disturbances?
Excessive sodium
Hypokalemia,
and
sodium retention.
Very good.
metabolic alkalosis.
Very good. And
Low
hypertension.
hypertension.
Low aldosterone. Very good. So how do you differentiate Conn syndrome versus Liddle?
Hyperaldosteronism along with hypertension is Conn's. And aldosterone suppression along with hypertension is Liddle.
Very good. Beautiful. So today we did a wonderful revision of sleep, hypothalamic nuclei, thalamic nuclei, and the these 4 important syndromes. I hope you all enjoyed the session. Every day evening, 6 o'clock with Dr. Murali Bharadwaz. And please bring all your classmates in the college. If more than 10 people join you, I can even conduct these sessions even on a Zoom link also. And shortly we are coming up with one mobile app called Wango in another 4 or 5 days. In the Wango, 24 hours, somebody or other can be conducting a 1-hour revision session. Once the Wango app is launched, I will tell you. It is a social audio app for education and healthcare. So you can find study mates. If you are feeling bored to study alone, no, you can simply start an audio chat room. You can make everybody else come, and then you can do the revision. You can share the materials, everything you can do. 24 hours, one or the other room, there will be one or the other discussion for the NEET PG will be going on. You don't need any coaching programs or anything. You can happily find study partners and study together on the Wango app. Before the app is launched, I am doing a pilot on this using the these online tools like StreamYard. So thank you very much for joining, and study well, study with energy, study with the hope. Hope is the only differentiator between a winner and a loser, right? Already we lose the game if we lost the hope, even before exam. And if we are hopeful, maybe whatever be the performance in our recent NEET PG, the next INA CET you are going to crack, all right? And always I'm there with you to become your classmate and study with you every day. Good night. Thank you.
Thank you, sir.
Thank you, sir.